I want to give just a little bit of a sort of more micro detail of some of that, because I'm aware of a lot of you in the room will be people who are going to be treating some of the victims of the Manchester Arena incident, but also you will encounter a lot of the workforce involved. And I particularly did this slide, and it isn't exhaustive, but bearing in mind what Paul said about the scale of the previous bombing in Manchester, I want you to take a moment to realise just how many of those people are across Greater Manchester, and actually wider across the northwest, and in fact even wider than that, because some of the family liaison officers came from much further afield, from the northeast and from Wales. One of the things that's really important about this is also, when I was doing this list, there isn't a hierarchy of need in this, because people say, oh, well, some people should be better able to deal with this than others, i.e. people who deal with it day to day. But the reality of it is that this has a very major impact if you're doing this as part of your job, and it kind of links a lot to what Noreen was saying. So it ranges from people who you might say, like mortuary and coroner staff, who are used to dealing with death on a day-to-day basis, but they're not used to dealing with an event such as this and the intensity of this event. And also you've got people on that list, such as the hotel staff in Oldham, who looked after the bereaved families for a really prolonged period of time. So whilst they had rooms that had families in them who were waiting to hear if their loved one was dead, they were also running christenings and weddings and other things out of the same hotel. And also we have the arena staff who were there in the building that night, who actually, a lot of them are on zero hours contracts and had basic first aid training. So what made this different is one of the things that I think, again, it links a lot to what was said this morning. It was the intensity of the event and also the type of trauma, especially because it involves children and young people. Anyone who's worked with any of our first responders will always say an incident that has children involved always has that sort of additional quality to it, because there's a sense of young lives being damaged by an incident. The scale of it is incredible. As I say, the police had to draft in a number of other forces to help them deal with it. And certainly I was up at the mortuary at the Royal Oldham Hospital, and it was one of the busiest places I've ever seen in terms of the numbers of people they had to draw in from other mortuaries whilst they were going through the process of trying to identify victims. And the Red Cross, who were there from pretty much immediately, they deal with disasters all over the world, and even they were commenting to me that it was quite difficult because they were suddenly dealing with so many disasters, terrorist incidents that were actually on home soil. So it felt very different to them as well. In the immediate aftermath, one of the issues was the length of time before the scene could be secured. And there was a documentary earlier this week, which some of you might have seen, that was quite critical about this. And I can tell you that the workforce involved felt that very strongly, that they wanted to go in earlier and be able to help people who were seriously injured. But there were very serious concerns that there could be a secondary device, or that the bomb could have been a dirty bomb, in which case if you had released people from that arena, the immediate area in the arena, they could actually then have contaminated lots of other people. So actually some of the decision making, and I want you to think that through, if you were the person making the decision about whether to let other staff into that environment, it's a pretty difficult decision, and it links to one of the comments I'm going to make later on. There were secondary issues that evening as well, which actually have a really major impact. So the Royal Oldham site, there was reports of gunshots fired, so it went into a complete lockdown. And they also had a suspect device, which when they were actually trying to deal with the immediate intake of victims, and the Royal Oldham was one of the nearest hospitals, there was also North Manchester, where people self-presented way before, within minutes of the actual bombing. But at the Royal Oldham, when they went into lockdown, there were lots of people involved, and how do you then try and help people who are already presenting at A&E, who are going through a secondary trauma that there might be a bomb in that department? There was issues subsequently about the length of time it took to identify all the victims, and lots of people spoke to us about this from the ambulance service, from the police, fire brigade, all of the people involved in terms of the acute hospital sites saying they couldn't tell people the information that they wanted to know. It was painstaking work, and I'm absolutely sure that that was echoed at Grenfell Tower when there were lots of issues about not being able to identify people quickly. So you're a relative waiting to hear for a long time, which then, as a member of a helping profession, it's really difficult to not be able to give people the answers they need. There were the areas around the people being out-of-area patients, and I think this is something which we may well personally have. I mean, a lot of you in the room helped out at these early stages, and there were issues about we were providing a standard of care that we couldn't necessarily guarantee was going to be followed up when people were transferred back to their own localities. And I think there were lots of complications of that because of the nature of people coming from Scotland, south of England, the north east, etc. I think people were really trying to dual process because they were trying to manage their own personal responses as a Greater Manchester resident. And that was really apparent when people were talking about, my daughter is this age, my daughter was at the arena last week, I have tickets to go to the arena next week. So people were processing it on a dual level and that sort of occupational level, or being involved in this as part of their job, but also then processing, I could have been there as well. And I think it was really interesting in what Noreen was saying about that sort of secondary trauma effect, about being able to visualise having sat in the arena and seen a concert maybe the week before, or being going to one, or having booked to go to one subsequently. And I think there were issues for people about their own emotional response and their ability to maintain boundaries. We spent a lot of time telling people that they needed to go home, and that they needed to take time to self-care, and that they'd done enough. And there seemed to be a sort of real desire to help that actually hindered people's ability to see their own restrictions within that. And actually, the tireder people got, the less valuable they were to the people around them. And in fact, it became really traumatising and was secondary traumatising other people. In the first 9 days, what I thought was really important was that we were really visible on the ground, and we were present, as Paul says, almost immediately, even though we weren't in the original plan. And I think this is a really important thing, that actually what's come out of this is that we've moved things on significantly to say that if there was a subsequent event, mental health and psychological well-being would be part of the actual plan and would be mobilised immediately. It was actually, we mobilised because we do what we do, and we had expertise, and I'll come on to that again in a minute. Some of it was a very softly approach. We weren't going in therapizing anybody, and we made that really clear. And actually what we did a lot of the time, links very much again to Noreen's list before, was we brought food to people. We were actually available. We helped do useful things. And we actually said what was the most useful thing, and then as a secondary bit of that, we might have explored, actually we're mental health staff, that's where we've come from, and then people would start to say, oh well, can I describe this to you, or actually can I ask you? And there was a real opportunity to normalise things in situ. So we were in the A&E departments, we were on the wards, we were very present. I think the thing is we also modelled, we role modelled, because we directly worked with patients and their families, and that's both children and adult services. And it was great because nurses were saying to us, what do we say? How do we manage this? So we were able to do it really live with people and say, I've got some guidance I've brought with me, you can keep, put it up on the boards, but actually here we are. And it allowed us to have some very useful conversations about things like, have you students here? So what support are the students going to get afterwards? How are your junior member of staff managing this? And it was excellent. We found some really psychologically minded staff within our communities. And the guidance that we give was there absolutely. I can't tell you how quickly people were writing this and cobbling together things, but it was really top quality. We had actually got access into acute care teams, which was fantastic, both at the central Manchester hospitals and also at the other hospitals where people had self-presented. And it was very, very valuable because we had existing relationships with some of our acute teams that we were able to use to kind of get the message out there very quickly. And we had a dedicated staff number and an email available within 2 days of the event. We attended the formal debriefing sessions, and again, I'll we can talk about the debrief issue. These were debriefs put up by our partner organisations, and we had to give some really good advice, I think, as we went to some of those about some of the messages they were giving to their staff. And in fact, there was one session where a very, very well-meaning person who had worked very hard through this process, we said to him maybe he could have just taken down a couple of the slides he was showing, because he was actually going to traumatise staff who hadn't seen some of those images, and he hadn't thought of it. It was just something that wasn't in his head because he hadn't sort of thought of that secondary trauma issue. And we give advice on the safety of other offers and the appropriate evidence base, which was really critical because the messages the media were giving were not all that helpful at the time. So what facilitated this? We had system leadership already, and we had expertise on evidence-based trauma approaches. And I think this was through things like, as Paul's alluded to, the clinical networks and our links to IAPT and the work we'd already done in terms of the IAPT collaborative over the years. And we had the Military Veterans Service in the Northwest that was seen as a really nationally recognised repository for expert advice on trauma-focused therapy. And we also had a really extensive piece of work that was ongoing around Greater Manchester's child and adolescent mental health and the Thrive model that they were operating, which we could really use and lift from that to actually apply some of its principles to the adult model and the adult pathways. We had existing relationships with acute care colleagues, the police, the North West Ambulance Service, the Fire and Rescue, and we had good relationships with some of our third sector colleagues. And again, I wanted to really draw that out, that although there were some offers that were really unhelpful, there were some offers that were fantastic. So, for example, the counselling offer that was through 42nd Street, which was really well thought through, and they actually pulled together a voluntary sector day, which a number of us were able to go to, where we talked about what was an evidence-based approach and what was helpful and what wasn't. And I think they appreciated that. There was also an incredible value in existing liaison services and our RAID teams who had the existing relationships with acute care colleagues and community colleagues. And I think what we have really seen was a willingness to work in partnership, which I suppose Devolution Manchester set some of the scene for that. But we have been largely separate organisations, but we've had to start to think, well, actually, we've got such a good skill set. And I think this drew us together in a way that was far quicker than any sort of organisational piece of work could have done. And especially to a lot of you in the room, there was a willingness to go the extra mile. And as Paul said, even to the point that the trusts haven't been paid for it yet, which is, we'll not mention that one again. The ongoing offer is that we're asking anybody who was involved in terms of that workforce to participate in the screening programme, and that means yourselves as well, actually, bearing in mind that you were part of that offer. And we want people to recognise there are existing structures that they can access, and Alan will mention this, I'm sure, in more detail, in that people may present to their local IAP rather in preference to doing something separate to that. They may go to their ordinary occupational health services, and they may go to staff wellbeing services. But to just flag up that the acute trusts are already identifying people who are really struggling and seeking support. And I'm sorry to say we also have had, I think it's 2 suicides within the workforce, which may, and again, may really be connected to issues that were happening before. And certainly in the hub, the first workforce people that started to trickle through were people where there were existing issues that were already there that were then tipped over by this incident. But Greater Manchester Police are already identifying 1,200 staff across GM and the other forces who were affected, and they're enhancing their own staff support offer. And NWAS, the ambulance service, is increasing access to private therapy because they feel that they're going to have a significant need. And I think there is a real growing awareness of the impact on people with pre-existing trauma issues. The reason I'm alluding to this as well as the senior staff offer was the people in Gold Command and Silver Command worked. These aren't people who are frontline clinicians necessarily, but they were the people managing the whole incident, including the police raids that were subsequently happening to try and apprehend offenders, etc. And this went on for a very sustained period of time. And some of those people find it really difficult to access help within their own systems, so that everybody knows them. So how do you then go and access help? And it links to the fact that there's an awful lot of stigma and trauma, stigma and cultural issues about doing that. Okay, I'm just going to skip through this, although I can mention later on, if people want me to, about the Swartz offer. We are trying to pulled together some best practice guidance as well in terms of if this were to happen again, what would it look like? I think most of these have been mentioned this morning, but one I did want to say was I think you'll find with workforce people often delay seeking help. They see that everybody else should have help before they do, and therefore when they come, some of the problems might well be more entrenched than you would see if they were immediately presenting. And I guess the other issue we've found a lot through the Military Veterans Service that does other work with police and fire service, people don't always trust their occupational health services and therefore might not want to present through that route. What we're asking people to do is encourage them to make contact with the hub. I maybe let Paul deal with this slide because I'm going to tell me I've only a very short period of time left. But what I would say is what we have offered is we know in the IAP workforce that we had a number of people who were already trained in trauma-focused CBT and EMDR, but it was patchy. And I think, I'm sure Paul Wallace would agree with me that in CAMHS, that in Greater Manchester, we've been able to deliver a very good offer, but that's not been true across the whole of the North West, where there's been some real areas where there's gaps. And maybe, Alan, you could allude to the other bits of training, so I'm not losing my time here. I did want to also go to this one, which is that it is difficult work, and what we identified with the hub that people would work part-time to avoid that burnout, and that actually we're subject to secondary trauma, and we may also have had cumulative trauma. And there's been a lot of discussion, and this may be something people want to talk about with the panel, is why is the arena bombing being given priority over anything else? And it was to reassure you that that hasn't been the case, that we've assessed people on clinical need, and that we know that people in the room are dealing with trauma on a day-to-day basis as well. I really encourage people to recognise your own vulnerabilities with it, and we tried to get the staff we responded to immediately to do that in terms of saying people with kids who are that age, people who've been to the arena recently, all of that stuff that we're talking about being able to put yourself in that, highlights that issue about your own vulnerability. And we were really wanting to emphasise that support and supervision element, but also looking after the teams that you're involved with and recognising that in the people on either side of you. And certainly one of the things we've learned is how important that was to look after us as a staff grouping who were delivering that response following the arena bombing. Thank you.